Okay, so welcome back to the second part of this lecture. On the first part of our lecture, what we have discussed is acute post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, good posture syndrome, Wegener's granulomatosis, Henoch purpura, membranous proliferative or membranous glomerulonephritis, and membranoproliferative glomerulonephritis. Now, what we have here is chronic glomerulonephritis. Okay. Now, remember, guys, that the degree or the possibility that a glomerular disorder will result to chronic glomerulonephritis depends on the amount or duration of the damage in the glomerulus. Okay? Damage in the glomerulus that can be brought by the previously discussed glomerular disorders. Okay, now, when we said chronic glomerulonephritis, what does it mean? There is a marked decrease in the renal function resulting from the glomerular damage by other renal disorders. Okay? It means that the problem that was caused by the different glomerular disorders make or yielded into a severe or chronic damage in our glomerulus. Okay? And take note that chronic glomerulonephritis may lead into what we call renal failure. Okay? May progress into what we call renal failure or end-stage renal disease. Okay? Now, what are the symptoms included in this problem? The problem includes, or the symptoms rather, includes fatigue, anemia, hypertension, edema, and oliguria. Fatigue, okay, because of what is happening. Now, anemia. Why is anemia uh, associated in chronic glomerulonephritis? Because as we all know, our kidney is the one that is responsible in the production of what we call erythropoietin. Erythropoietin is a hormone that will give signal to our bone marrow to have what we call hematopoiesis or the production of what we call RBC. Now, since that you have a problem in the production of your RBC, there will be a anemia. Okay? Anemia at ang origin niya is hormone deficiency or anemia due to chronic disease, chronic kidney disease. Okay? Now, why is there is a hypertension? There is a hypertension that is because of the blood that passes through there is an increased pressure in the blood that passes to our kidney. Okay? Next, mayroon din pong hypertension. It is because our kidney fails to regulate the level of sodium and water in the blood, in the body. Edema, no? Since there is a failure in the regulation of water, instead of being secreted, because you have a problem, you develop oliguria, no problem in urination, decrease in urination, no? Instead of being the water being excreted, the water deposits in our tissue. Those are the problems why those are the symptoms seen in chronic glomerulonephritis. Anemia, because there is a problem in the kidney in the formation of our erythropoietin. Blood or erythropoietin, impaired production of the erythropoietin means there will be a problem in what we call hematopoiesis or production of red blood cell. That will yield into anemia. Hypertension is possible because the problem in the glomerulus, there is an increased pressure of blood that coming into the glomerulus, which make the glomerulus fails to filter well the blood. Bakit po nagkakaroon ng hypertension? Because of the problem in the water and sodium regulation. Bakit po nagkakaroon ng edema? It's because our urine, our water, the excess water in the blood, mataas ang water level. That's why it causes hypertension. Mataas yung water level, hypertension, hindi mo ma-urine, hindi mo ma-excrete, then you develop edema because the excess water that should be excreted that causes hypertension is being deposited in our tissue. Okay? So that is our chronic glomerulonephritis. Now, what are the medical tests or laboratory tests for chronic glomerulonephritis? Well, basically the same thing as what we have in all our glomerulonephritis. Hematuria, proteinuria, broadcast. And there is what we call glycosuria or glucosuria. Why is glucosuria or glycosuria possible? Glycosuria is possible because it is a result in the tubular dysfunction. Okay? Ano pong ibig sabihin? Since our glomerulus is impaired, hindi na na-filter lahat ng sugar na dapat nilang ma-filter. And our tubules fails to reabsorb everything because of the too much number in the glucose. Okay? A person with chronic glomerulonephritis might develop or will have decreased glomerular filtration rate. Now remember that chronic glomerulonephritis is present in conjugation with increased BUN and creatinine level as well as electrolyte imbalance. Bakit po mataas? Again, ang ating BUN and our creatinine, that organic compounds assesses the overall function of our kidney. Tama? Di ba? As we mentioned before, our creatinine and BUN assesses the overall function of our kidney. Why there is an electrolyte imbalance? Again, it is because of the problem in the selection or in the filtration. The problem in what we call filtration. Okay? Next in line is we have immunoglobulin nephropathy. Immunoglobulin A nephropathy, also known as the Berger's disease. In this disease, there is a deposition of IgA. Wait lang, sir. Wait lang, guys. Don't be confused because we have two conditions wherein we have the deposition of IgA immune complexes. The other one is your rapidly progressive glomerulonephritis, and the other one is the immunoglobulin A immunoglobulin A nephropathy, or also known as the Berger disease. Okay, now what happened is the deposition of immunoglobulin A or IgA on the glomerular basement membrane or in the glomerular membrane resulted in an increased level of serum IgA. Now, what will happen? If there is a increase on the serum IgA, this will result into a mucosal infection. Okay? And this condition is usually seen in children or young adults. Okay? Now, take note, guys, that the patient with immunoglobulin A, deposition of immunoglobulin A on our glomerulus will lead into what we call problem in our glomerulus. So usually, the patient with immunoglobulin A nephropathy, or also known as IgA nephropathy or Berger's disease, will have an episode of macroscopic hematuria, okay, following and macroscopic hematuria, following hematuria, or infection, or even in strenuous exercises. Now, there is a gradual progression to chronic glomerulonephritis and eventually to ESRD. But what this condition or what makes this condition different from the others? Because this condition is or can be asymptomatic for almost 20 years, and then it will develop or the signs and symptoms will be shown. And knowing, hindi mo alam that you have already this condition. And take note guys, that this condition may lead into chronic glomerulonephritis or even a renal disease, or what we call end-stage renal disease. Okay? So, for laboratory diagnosis, well, of course, that is microscopic and macroscopic hematuria. And then for the late stages, that is synonymous with our chronic glomerulonephritis. Okay? Ano nga ulit yung laboratory examination ng patient with chronic glomerulonephritis? Hematuria, proteinuria, glycosuria due to renal damage or tubular damage, and presence of CAS, which includes broadcast. Next is we have nephrotic syndrome. Nephrotic syndrome, the problem here is not only the glomerulus, but the nephron itself. Okay? The problem here is not only our nephron, not only our glomerulus, but also our nephrons. The nephron itself is the problem. And in nephrotic syndrome, there is what we call massive proteinuria, which exceeds to 3.5 grams per day, which resulted into low level of serum albumin. I hope at this point in time, you were able to correlate why there is a low level of serum albumin, and then there is a high level of protein in the urine. If you still remember my discussion in electrophoresis, I've discussed that. So please remember why these things happen. Mababa yung protein level mo, yung albumin level mo in the serum, it is because the blood that contains our serum, that contains our protein, passes through our urine, through our glomerulus. And since there is a problem already in the glomerulus, a problem within the nephron itself, and part of the nephron is the glomerulus that filters the blood, that repels protein, that prohibits protein to pass the glomerulus, then the protein, particularly the albumin, passes through the glomerulus and then excreted in the urine. That is the problem why, or that is the reason why there is a low level of serum albumin in the blood or in the serum, but there is a high number of protein in the urine. So please take note of that. Now remember guys that during the onset of the disorder, circulatory disruption protecting septic shock that will produce a septic shock. Okay? And remember that nephrotic syndrome will gradually develop into what we call renal failure. Okay? Glomerular disorder, then renal failure. Remember, yung ating mismong nephrotic syndrome, yung ating mismong glomerulus nasira na din, that yields into a problem within the whole nephrons, then eventually lead into what we call okay, what we call renal failure. Okay? The question is, sir, what do we mean by septic shock? Or, I'm sorry, septic shock. Systemic shock, I'm sorry. When we said systemic shock, that is a condition, okay, which is a complication of a infection. Okay? That is a complication, okay, of inflammation. Okay, that causes destructive changes in the body. Okay, now when you experience septic shock, there is a significant drop in the blood pressure and then lead to respiratory failure, stroke, failure of the other organs, which includes kidney, that will yield into a death. Okay? So that is what we call nephrotic syndrome. Now, what are the laboratory findings that suggest, not the primary laboratory findings that will suggest nephrotic syndrome? Heavy proteinuria or marked proteinuria, microscopic hematuria, no? We also have the urinary fat droplets, okay? We also have the oval fat bodies, the RPE cells, epithelial, fatty, waxy cast, and even microscopic hematuria are the primary laboratory results for our nephrotic syndrome. Okay? Now, what is minimal change disease? Okay. Minimal change disease is a disruption of the podocytes. Again, when we said podocytes, those are that can be found on our glomerulus, not the cell or the membrane of the glomerular membrane. Okay. Now, remember, as the name implies, minimal change, it is also known as the lipid nephrosis, okay, which produces little cellular changes in the glomerulus. Okay, remember, there is a disruption of what we call podocyte occurring primarily on the children after allergic reactions and immunizations. Okay, and remember, this is frequently uh, remission following corticosteroid treatment. So, if you receive steroids or if you have a medications with steroids, pwede po tayong gumaling. Okay? Patients with is usually female, usually male, usually children, usually children who presents with edema, proteinuria, hematuria, but normal BUN and creatinine results. Okay? Now, the etiology is unknown. That is the time of the reaction, the allergic reaction, the recent immunization, and position of human leukocyte antigen B12 or HLA B12 have been associated with the disease. Okay, so these are the laboratory findings of minimal change disease. So remember, guys, the disorder responds well with corticosteroids and prognosis is generally good. Okay? Generally good, ibig sabihin, madali siyang nagagamot naman siya. Now, how about focal segmental glomerulosclerosis? Okay? So we have focal segmental glomerulosclerosis. Again, there is what they called a disruption also on what we call podocytes in a certain areas of the glomerulus. Hey, remember guys that focal segmental glomerulosclerosis affects not only the number and areas of glomerulus, but and the other and the other one remains normal. So part of it, no, is affected, but the other part is normal. Now take note of this. Focal segmental glomerulonephritis is usually or commonly associated with the use of heroin, analgesic, and person with AIDS. Okay? Now, there is a resemblance of nephrotic syndrome or minimal change disease. In other words, no, focal segmental glomerulosclerosis is almost resembling nephrotic syndrome or minimal change disease. Okay? What are the laboratory tests that suggest focal segmental glomerulosclerosis? I'm sorry. This includes proteinuria, microscopic hematuria, and the other significant test is our HIV test or drugs of abuse. Why drugs of abuse? Because of heroin and analgesic abuse. And why HIV test? Because of. Now let's go to our tubular disorders. When we said tubular disorders, this affects the tubules of the nephrons or of the kidney. No? Tubular disorders may be due to or affecting the tubulars or the renal tubules. It could be because of the metabolic disorders or hereditary disorders. And remember, people, that tubular disorder includes a problem in the renal tubules, or it is because of the metabolic disorder, or because of hereditary disorder that affects the function of our tubules. Now, the first thing that we are going to discuss is acute tubular necrosis. Okay? Acute tubular necrosis. When we said acute tubular necrosis or necrosis, there is a destruction on the normal pattern of our tissue. When we said necrosis, no, nabubulok na yung ating cells. Now, why there is a damage? Why there is a necrosis? Necrosis is due to the damage in the renal tubular cells. Why there is a damage in the renal tubular cells? Because of what we call ischemia. Okay? The lack of oxygen to the tubules, or because of the toxic agents. Because there is a lack of supply of oxygen in the tubules, it causes damage in the renal tubules. And this damage in the renal tubules, no, develops into what we call necrosis. Now remember, guys, that this order causing ischemic ATN or acute tubular necrosis includes shock, trauma, or surgical procedures. Again, those problem, no, or conditions that causes ATN at ischemic ATN includes shock, trauma, or surgical procedures. Again, remember, I will write shock. What is shock? Wait, I am not sharing my whiteboard. Okay. And remember, guys, that shock, okay, is a condition that is generally, or a general term rather, a general term indicating severe condition, indicating severe condition that decreases the flow of blood, that decreases the flow of blood throughout the body or through the body. Again, it's a shock. That is a general term indicating severe condition that decreases flow of the blood in the body. Okay, that's why it developed a problem. Next, wow, amazing mark. I have include pala in my PowerPoint presentation. I'm sorry. Okay, so, my God. A shock is a general term indicating a severe condition that decreases the flow of blood throughout the body. I thought I delete this one. Okay? And shock will eventually develop into a cardiac failure, sepsis, anaphylaxis, massive hemorrhage, or contact with a high voltage of electricity. Okay? So exposure to a variety of nephrotic toxic agents such as drugs, which include but not limited to aminoglycoside antibiotic, antifungal amphotericin B, cyclosporine, no, radiographic dye or organic solvents such as ethylene glycol, no, ethylene glycol poisoning, ano yung pwede natin gamitin pa microscopic examination sa ethylene glycol? Correct, calcium oxalate, ang galing mo naman. And then heavy metals that can cause problem in our tubules. I can move on, no? I write pa, nandun naman pala sa aking video, ang nasa slide ko pala ang siya. My God. Okay? So, acute tubular necrosis includes the laboratory findings of mild proteinuria, microscopic hematuria, presence of RTE cells and cast, okay, and then hyaline, granular, waxy, and broadcast. Okay, my God, Mark. Next in line is we have Funconis Syndrome. Okay, when we said Funconis Syndrome, there is a failure of the tubules. Pinag-uusapan na natin dito mga kapatid is tungkol sa ating what you call this? Tungkol na po sa ating mga hereditary or metabolic disorders, no? Particularly that affects the functions of our tubules to perform or to do its function, okay? In Funconis syndrome, that is associated with the problem of reabsorption in the proximal convoluted tubule. Now, having said that there is a problem on the reabsorption in the proximal convoluted tubule. So what are the analytes? What are the macromolecules that have been na hindi na filter? Well, of course, it includes glucose. The reason why there is a glycosuria in a person with Funconis syndrome. Okay, take note of that. No? Meron po tayong glycosuria in Funconis syndrome. If you still remember our discussion last time, there is what we call presence of glucose in the urine but normal blood glucose. That is due to the problem in the proximal convoluted tubule that reabsorbs the glucose from the glomerular filtrate. Normal yung blood glucose because the presence of glucose in the urine is not due to diabetes mellitus. The problem, guys, I hope that you are with me, no, understanding why there is a glucosuria, ha? Ulitin natin. The problem in this disease is the reabsorption in your proximal convoluted tubule. And the major function of your proximal convoluted tubule is the reabsorption of macromolecules, which includes glucose. Since there is a problem, since that glucose can pass through our glomerulus, no, it will be present in the glomerular filtrate. Therefore, since the problem here is your tubules, your tubular, which fails to reabsorb the glucose, there is a presence of glucose in the urine, which we call glycosuria or glucosuria. However, even though that there is a presence of glucose in the urine, glycosuria or glucosuria, blood glucose is normal. If that is the case, then that condition is due to Funconis Syndrome, because Funconis Syndrome is a problem in the proximal convoluted tubule, most especially the reabsorption. Okay? Next, it is also associated with inherited disorders such as the problem in cystine, cystinosis, or cystinuria, as well as heart nut disease. These two conditions are conditions associated in the excess of what we call amino acids, which will be discussed in the next chapter. The problem in these amino acids is because our tubules failed to reabsorb these amino acids, the proximal convoluted tubule. Okay? Or the problem that might lead into heart nut disease is because there is a problem or deficiency in the enzyme that will convert one amino acid into other. Funconis syndrome may also be due to acquired exposure to toxic agents. Since sodium and potassium is reabsorbed in proximal convoluted tubule, then we can say that in Funconis syndrome, we could have a problem in our electrolyte. Okay? We could have a problem into our electrolyte. Okay? So these are the laboratory findings for Funconis syndrome: glycosuria with normal blood glucose, possibility of having a mild proteinuria, okay, possibly cystinuria because of the failure to reabsorb amino acids, and very low pH due to the reabsorption of our bicarbonate. Failure to the reabsorption of our bicarbonate. So that is the problem. Okay? Next is we have Alport Syndrome. When we said Alport Syndrome, this is an inherited disorder of the collagen production affecting the glomerular basement membrane. This is a X-linked gene inherited, mostly affecting female in an autosomal gene. Remember guys, that Alport Syndrome will lead into nephrotic syndrome that will eventually lead to end-stage renal disease. Okay? Alport syndrome includes what? Hematuria, microscopic and macroscopic hematuria. Now, how about uromodulin-associated kidney disease? Okay, remember guys, when we said uromodulin, this is a glycoprotein, and the only protein produced by the kidney. Okay? Kaya nga, yung matrix ng protein na uromodulin is an assumption that there is a problem in the kidney kasi si kidney lang ang pwedeng mag-produce ng uromodulin. Tandaan mo yun. Okay? And this is produced by proximal convoluted tubule and distal convoluted tubule. Okay? Again, remember guys that uromodulin-associated kidney disease is a inherited disorder caused by autosomal mutation. Okay? And the mutation causes a decrease in the production of the normal uromodulin that is being replaced by the abnormal form. Now, abnormal form is still produced by the tubular cells and accumulate in these cells. And once accumulate, then it can cause the presence of the cast. Okay? Mutation causes includes in the uric acid and as well as gout as early as teenage. Now, how about the diabetic nephropathy? This is the most common condition or cause of end-stage renal disease. Remember guys that diabetic nephropathy is a damage to the glomerular basement membrane or glomerular membrane. And the reason to that is number one, result of glomerular basement membrane thickening. Number two is increase in the proliferation of the mesangial cells. And number 3, increase in the deposition of cellular and non-cellular material. Now remember people that diabetic nephropathy is associated with the deposition of glycosylated protein. Okay? Take note that the damage, is due to these 3 conditions. Ngayon, this glomerular damage is believed to be, this damage is associated with glycosylated protein. Okay, now take note that the vascular structure of the glomerulus also develop sclerosis. Okay? Kaya, di ba guys, kapag ikaw ay may diabetes, yung isang problem is because of what? Ang isang nagiging sakit mo is problem in the kidney because of the drugs that you intake that affects the function of our kidney. Okay. Take note, guys. In order for us to evaluate or to remember this, if you still remember in the chemical examination of urine, ano po yung sinabi natin sa chemical examination of the urine? Di ba meron tayong tinawag na uromodulin? Microglobulin, right? Meron po tayong tinawag doon na microglobulin or microalbuminuria. Now, this is important to detect the onset of diabetic nephropathy. Okay? So we have nephrogenic diabetes insipidus. So I believe I have discussed this already, but let's have a review again. The problem in nephrogenic diabetes insipidus is the failure of the hypothalamus to produce enough antidiuretic hormone, amounts of urine. Okay, failure of the hypothalamus to produce ADH. Remember, si hypothalamus ang nagpo-produce ng antidiuretic hormone. Si posterior pituitary gland ang nagre-release, ang nag-i-store. Okay? So the problem here is nephrogenic diabetes insipidus. So the problem here, wala po tayong sa target natin, sa tissue, sa kidney natin, the problem is wala pong sensitivity, okay, sa ating ADH. Now, this is seen in complication of polycystic kidney disease, This is seen in polycystic kidney disease and of course in sickle cell anemia. Now, the laboratory findings will definitely low specific gravity of the urine, pale yellow color of the urine because of it is diluted, because of the overproduction of water, and false negative results to a chemical test. Why? Because the urine is diluted with water. Next is we have renal glycosuria. Okay? Renal glycosuria affects the reabsorption of the glucose. Thus, if there is a problem in the reabsorption of the glucose, it means that there will be a possibility or there is a presence of glucose in the urine. Okay? This is an inherited autosomal trait disease. And take note, guys, that the glucose transporters in the tubules is decreased. Okay, again, take note also that there is a low affinity or affinity of the transport of glucose is decreased. Now, again, remember that there is increased glucose concentration in urine, but normal blood glucose. Next in line is we have the Intersysteal Disorders, which affects the tubules. Intersysteal Disorders is due to infections or inflammatory conditions. A while ago, what we have is tubular disorders. That is, the problem on that is because, number one, either hereditary or metabolic disorder. Okay. Now, one of the most common type of interstitial disorder is the urinary tract infection. Okay, remember guys that it involves the lower and the upper respiratory tract, urinary tract. When we said lower urinary tract, which includes the urethra and the bladder, upper urinary tract includes the renal pelvis, tubules, and even the interstitium. Alright, so we have first cystitis. Okay, what do we mean by the word cystitis? When we said cystitis, that is the inflammation of the bladder that might progress into what we call urinary tract infection. The infection of the bladder is due to what? Okay, ascending bacterial infection to the bladder, multiplication of bacteria in the bladder, okay, acute onset of the urinary frequency and burning resolved with antibiotics. Again, if you will have the review of our bacteriology class, if you said that urinary tract infection among women, young women, or if we can also say that this is the most common cause of urinary tract infection, lower urinary tract infection in women, that is Escherichia coli, right? And if we have UTI, the drug that can be prescribed to you is what? Ciprofloxacin. Okay? Ciprofloxacin will be the drug that will be prescribed to you by your doctor. Okay? Now remember, that cystitis may be resolved. UTI, yeah, simple UTI. However, as we go along, you will see and you will observe what I have said in my introduction, from a simple UTI into end-stage renal disease. We will have to discuss that. Okay, laboratory diagnosis or laboratory findings includes leukocyturia, or the presence of WBC in blood, in urine rather, bacteriuria because of the bacterial infection, microscopic hematuria, mild proteinuria, and even increased in the pH. Okay? Now we have here acute phylonephritis. When we said acute phylonephritis, okay, remember guys, that is a infection of the renal tubules and interstitium. Okay? That is a infection of the upper urinary tract, which includes the tubules and the interstitium. Okay, remember guys that the term phylonephritis can be the term phylonephritis can occur in both acute and chronic forms. Meaning to say, we have acute phylonephritis and we have chronic phylonephritis. Okay? Remember that acute phylonephritis is the most common or the most frequently that occur as a result of ascending movement of the bacteria from the bladder, okay, from upper urinary tract into the renal tubules. Then eventually from renal tubules to interstitium. Okay? Yung cystitis, ano lang siya? Lower urinary tract infection. Yung acute phylonephritis, upper urinary tract infection. Okay? Okay, so this is usually resolved by antibiotics. Now, yung burning, when said burning, difficulty in urinating or painful urination, okay, and lower back pain. Okay, usually yung tinatawag kidney punch, to know if the origin of the pain in the lower back is kidney, and that is resolved by giving what? Antibiotics. So the following includes the laboratory findings: Glycosuria, bacteriuria, WBC, bacterial infection, bacterial cast, microscopic hematuria, proteinuria, blood culture, and urine culture might be useful, no, for chronic or for acute phylonephritis. Now we have chronic phylonephritis. Okay, this is a recurrent infection of the renal tubules, recurrent infection of phylonephritis from acute nephritis na bumalik that causes a severe form, which is a chronic phylonephritis. Okay, as the name implies, chronic, this is much more serious than the other one. And since this is chronic, no, it can give us, or it can result into a permanent damage to the renal tubules. And since there is a permanent damage into the renal tubules, there is also a possibility that it could progress into renal failure. Okay? Now, what are the laboratory findings? Laboratory findings includes leukocyturia, bacteriuria, WBC cast, bacterial cast, waxy, granular, and broadcast, as well as hematuria and proteinuria. Now, what you observe? A while ago, in glomerular disorders, mostly ang unang sinasabi is what? Hematuria, macroscopic hematuria, microscopic hematuria, RBC cast, and so on and so forth. Because the problem on that is more on what? Glomerulus deposition or destruction on the structure of what? Our membrane of our glomerulus. Damage. In these interdistill disorders, ano yung usually unang binabanggit? Leukocyturia, bacteriuria, WBC cast, bacterial cast, and list is hematuria and proteinuria. Why? Because the origin of this is what we have said, is the problem due to infection, due to inflammation from a simple cystitis, no? Nagkaroon ng production ng microorganism in the bladder that yields into a upper urinary tract infection. Eventually, it was nagkaroon ng remission, gumaling, when eventually bumalik, and that is your chronic phylonephritis. I hope that you will get my point na you can use these laboratory parameters to easily identify whether as it is a glomerulonephritis or glomerular disorder or interstitial disorder. The other one, yung diniscuss naman nating tubular disorders, those are the problems within the reabsorptive capacity of the proximal convoluted tubule, which resulted in glycosuria, amino acids in the urine, and protein in the urine. Particularly what? The uromodulin. Okay? So other significant tests for chronic phylonephritis includes urine and blood culture, BUN, creatinine, and creatinine clearance. Okay? So we have here acute interdistill nephritis. Okay? Again, guys, take note that there is a marked inflammation of the renal interstitium followed by inflammation of the renal tubules. Okay? This is an allergic inflammation of the renal interstitium in response to certain medications. Okay? So, there is a possibility of renal dysfunction in acute interstitial nephritis. Well, this can be resolved following the discontinuation of medication and treatment with corticosteroids. Okay? Now, remember guys that in acute interstitial nephritis, the primary it is primarily associated with allergic reactions sa mga medications. That's why, ang sabi natin dito, It is usually resolved following the discontinuation of the medication. Okay? Why? Bakit nagkakameron nun? Because of the possibly caused by the binding of the medication to the interstitial protein. Now, symptoms may be experienced after 2 weeks following the or 2 weeks after the administration of the medication. Okay, so the laboratory findings suggest hematuria, proteinuria, leukocyturia, and WBC cast, and other significant tests, which includes urine eosinophils. Take note. This is what I have told you in a microscopic examination. Diba? 1% of the 1% of eosinophils in the urine is considered significant, which might be due to allergic reaction that caused by the drug. Okay? And that is seen into acute patient with acute interstitial nephritis. Well, BUN and creatinine will always be there because that is our organic substances that can be found in the body that will assess us the overall function of the urine. Okay, so we have here creatinine clearance also. Next, I guess this is the last but not the least about renal failure. Okay, renal failure can occur into both acute and chronic forms. Okay, renal failure is almost synonymous with end-stage renal disease. Again, I'm so sad to say that as of the moment, as of the record, there is no exact medication for renal failure aside from there will be a renal transplant. Pero ito gusto ko tandaan nyo. Kapag po kayo ay mayroong renal transplant, hindi naman inaalis yung kidney mo na mayroong problem. Ano yung ginagawa? Dinadagdagan ka ng kidney who will do the function of the kidney with problem. Now, what is the moral lesson at the end of the day? The moral lesson of the end of the day is you should take care of your body. Avoid foods that will destroy our kidney. Avoid too much consumption of drugs that can cause problem when you become old. Drink plenty of water. Drink enough of water. Okay? You are still young. And it is sad to say that as early as 20-year-old, as early as 19-year-old, as early as 15-year-old, meron na pong mga patient na ina-undergo ng dialysis. Those conditions might because of the hereditary conditions or because of the conditions that is seen usually in children. But mind you people, as early as now, that you can still improve the diet that you have. Please improve the diet. Do not eat too much of salty foods that can destroy the function of our kidney. Because remember, there is no drug that can heal the damage in our kidney. The only medication, the only treatment that you could have is kidney transplant. Dialysis is not a treatment. That is just a supplement to our kidney. A supplement to do the function of the kidney, which is to filter the blood. Because if you will not undergo dialysis, metabolic waste products will be in your body that can cause harm to you. Could you imagine, from a simple urinary tract infection that could lead into a renal failure that will eventually cause you suffering, that might cause your death. Remember guys that end-stage renal disease is associated with decrease in the glomerular filtration rate, rise or increase in the BUN and creatinine, electrolyte imbalance, producing isostenouric urine, protein and renal glycosuria, and all of the cast that can be possibly seen in your urine. Okay? Acute renal failure, sudden loss of the renal function. Okay? Sudden loss of the renal function. Frequently reversible. Swerte ka if you have acute renal failure. At least somehow, you still have a chance to recover. Because frequently reversible. Frequently. Okay? What are the primary causes of acute renal failure? Primary causes of acute renal failure include sudden decrease in the blood flow to the kidney. Kaya minsan, ano nangyayari sa'yo? Nakakaroon ka ng collapse. Nagko-collapse ka because of the sudden decrease of blood flow in the kidney. Acute glomerular and tubular diseases, which we have discussed a while ago. Renal calculi or tumor obstruction. Calculi stones. Renal lithiasis will be discussed later. Or tumor obstruction within the kidney. These are the problems with acute renal failure. Okay? Now, the renal failure can be classified as pre-renal, renal, or post-renal. Pre-renal, if there's a decreased blood pressure or cardiac output that blood flow to the kidney, hemorrhage, burns, surgery, or septicemia. For renal, which includes acute glomerulonephritis, acute tubular necrosis, acute pyelonephritis, acute interstistial nephritis, within the kidney is the problem. Or post-renal, renal calculi, or tumors. Okay, now how about renal lithiasis? When we said renal lithiasis, this refers to the renal stones or renal calculi, no? From calyxes to pelvis of the kidney, ureters, and bladders. So the renal stones or renal lithiasis, the stones can be seen on the calyxes, pelvis of the kidney, ureters, and bladders. Okay, remember guys that the most common combination or the most common cause of renal lithiasis is accumulation of what we call calcium oxalate. Okay, that is often found in stones at 80%. Calcium oxalate, mixture of oxalate, and mixture of oxalate as well as our calcium phosphate. Well, I guess this is not in your book, so please have the copy of this one, have a screenshot of this one. Okay, mixed calcium phosphate, magnesium ammonium phosphate, and uric acid is the next most common constituent of the renal calculi. Cystine stones is the least cause of renal calculi. Okay, again, calculi varies in sizes. Okay, and remember guys, we have what we call the staghorn calculi, which resembles our renal pelvis. Take note that uric acid and urate stones, is typically a yellow to brown, red, and moderate hard. Okay, phosphate stones usually pale or friable. Calcium oxalate stones often hard, of a dark color, and then cystine stones usually a brown color and somewhat greasy. Okay, so these are the diseases in our kidney. Again, kidney is a major organ of the body. Okay, my key away points is to remember that kidney is an important part of the body. It serves multiple functions. That is the reason why urine is a useful parameter, a useful blood fluid in assessing the function not only of the kidney but the overall function of the body. That's why, second point, I am encouraging you to take care of your body, most especially your kidney. You save your kidney, you save your life. You save your life, you save money. You save money, you can afford to buy something that you want to have. Not to afford drugs, not to afford medications for kidney, but to afford something that you really want to have. And as a student of this course, the third key away point is remember where we start. We start from a physical examination, chemical, microscopic, and here we are in the renal diseases. Thank you very much, and I hope you learn, no, in this lecture. Thank you and have a nice day, everyone.